With that, I'm going to go ahead and introduce our keynote for this afternoon. Mr. John Teeter, who is the Managing Global Director for the Global Center of Excellence for Health at KPMG. As part of KPMG's global team of health and human service professionals, he promotes the effective use of information technology in support of health and human services projects, programs, and initiatives globally across both the public and private sectors. John is also the former acting CIO and before that, the Chief Enterprise Architect for the U.S. Department of Health and Human Services. In these roles, he is responsible for all aspects of information resource management, including several enterprise programs and the development, maintenance, and use of the HHS-EA. And I have to add, John's been actually, most of you know our sister organization, GTRA. John was one of our original council members back in the day when he was in government, so it's really exciting to be able to work with him and his new career path. So John, good to have you back, and please help me welcome Mr. John Teeter.
We okay? Yeah, I guess we are. Good afternoon, I guess. I should probably tell you that we've got about 30 minutes here, and Parm wanted me to tell you everything that I've learned about information technology and support of health that I happened over the last 3 decades. So that means there'll be plenty of time for questions at the end. So what I'd really like to talk to you a little bit about today is just, throw out some of my ideas, and for some of you that have been in sessions with me already today, you'll know that I have a bunch of them, and I'm not too shy about expressing my ideas. But the title is Then Healthcare Then, Now, and in the Future. I'm not going to dwell too much on the then, a little bit on the now, just to kind of set the stage. But what I really want to talk about is the future. And I think that's what we're all struggling with, and what is our place in this new future that we see forming before our eyes. And so what I want to talk about is, when we get to the future, I want to talk about some of the foundations that I see as driving change for the future. And some of those are moving towards prevention, patient engagement, provider transition, payment reform, and then lastly, but I think very importantly, performance analytics, because I think a lot of things are going to be driven based on data-driven decisions that are the result of pattern identification that maybe we haven't even seen yet. And so I think that's going to be an important part of our discussion. And I might say too that I do want this to be a discussion. So if I come up to you and I say, and what have you done? What have you done in this area?
A lot.
There you go. So that's the way it's going to work. I actually find that as you can tell, I'm a little bit of an informal type of a person and an informal type of a speaker. But what I really do find is that I like these events. I like the Health Tech Council type and the GTRA type of events, because it does allow me to do these kind of things, and I learn just as much from you all as hopefully you'll learn from my perspectives. So healthcare then is, we all know that this is the way it was in the last few years. Non-integrated care, addiction to volume rather than quality. So you get paid by volumes of treatments or volumes of drug sales, et cetera, et cetera. Treating episodes of sickness rather than concentrating on wellness, and waiting for something bad to happen before we take an action. Fee for service is a large piece of the then, mostly provider focused. Everybody, it was centered around the fees that the providers were going to get, and the patient was while they were not out of the equation totally, the whole business model was not focused on the patient. It was focused more on the providers and the payers, and a lot of the activities were retrospective in nature. Anybody disagree with this as what it used to be? And maybe in some cases still is? Okay, all right. So, healthcare now. This is kind of what we're faced with now. And these are just examples of pieces of legislation that are kind of driving us towards, different things. At the very top there, you've got the Affordable Care Act. And somebody commented today, I forget who it was, that the full title is Patient Protection and Affordable Care Act. And there was this particular piece of legislation is what, 1,000 pages long, and if it's supposed to be patient protection, but if you do a search throughout the act, you find that patient is mentioned 400 times only in 1,000 pages, and so that's a different thing. Most of the focus has been on the affordable piece of this, and since I came from HHS. I know that, as this discussion was going on and this piece of legislation was being formed, there were basically three things. Now, there's other things, but basically three things that it was focusing on, and that is bending the cost curve was one, but having accessibility to health insurance and increasing coverage was clearly one of the main ones. And then as a third, it was the quality of care, the improvement of the quality of care. And so you start to see different things in the act associated with that. Now, depending on who you talk to, there's about anywhere from 13,000 to 20,000 pages of accompanying regulations associated with this piece of legislation. So the legislation provided the framework, the regulations get down into the nitty-gritty of how you're supposed to do things. And so we've all been struggling with that as it moves forward, because some of the regulations, even though we're supposed to be implementing this in a very short time frame, some of the regulations haven't even been finalized yet. So that's a challenge in and of itself. So this is kind of the environment that we're faced with. We've got all of these things that we're required to do and we're reacting to, and it really is really doesn't fit in our current operating models very well. So here's what I think that we're faced with, and that is that driving the healthcare transformation from the then over to what it's intended to look like, and I say intended because we don't know whether this. I'm going to call it a grand experiment or a focused attention on improvement, whatever you want to call it. We don't know whether this is actually going to be the result. So in tomorrow's world, you're going to have, I think, coordinated and integrated care. We're being incentivized to do that. Focus on quality and value rather than volume of treatment. Wellness and disease management so that you prevent the need for costly healthcare treatments down the road. In other words, this is one of those things where it's going to bend the cost curve downward through prevention and wellness rather than just waiting for something bad to happen and then reacting to it. Bundled and at-risk payments, we're going to see a lot of considerations of those things as part of your risk mitigation and payment models. Patient-focused, obviously there's going to be more choice for the patients, as they entertain the mandate for insurance coverage, and there's a number of ways to deal with that mandate too, and on both the patient and the employer side, and the jury's still out on which option employers and patients may take. It's going to be we're going to move towards more real-time and predictive. This is where you have different types of information that is at your fingertips. Maybe this is where, again, we have, the pattern recognitions across various overlays of information that might lead us in a direction that we are not currently pursuing. And then personalized targeted care. I think that, we're starting to see some of this in the areas of mobile technologies, where the patient is now more engaged in their own wellness perception, and where even patients that leave hospitals and are in what would typically be a recovery type of a state, sometimes we're seeing, and probably more so than ever before, we're seeing these recoveries happen in a home setting, because now because it's cheaper, less risk than staying in the hospital in some cases, and the technology allows us to do this. So this is what I kind of see, and what I'd like to do is I'd like to kind of walk through some various manifestations of all of that. But first, does anybody want to offer a different perception of where we might be going?
Hi, Robert Sheasley, UPMC. I don't have a different perception per se. I think you covered it. I think the one thing, and it may not be applicable for the next 15 minutes remaining that we have, but the pink elephant in the room is the payment models. And you did talk about the fee for service versus quality. So if you could just, based on your experience and conversations at much higher levels than I ride, I'd be curious to hear your thoughts.
Great, thank you. And I will touch on that. So I guess I should probably advance this. And so, I'm sorry, that didn't come out real well. But on the bottom here, these are some of the things that I see as foundations for healthcare transformation. And on the bottom, I'll just read them to you. On the bottom is regulatory change, and that's right there, regulatory change. The next one is target operating model transformation, and some of that is going to be across here. The third foundation is technology enablement, and then the fourth, I believe, is data services. So there's a lot of folks in this room that offer data services, they offer technology services, and I think all of that is going to have to be framed within these, as you rightly point out, these different operating models and the payment models associated with that. And then they're going to be incentivized or framed around the regulatory changes that are coming out. But largely, I see, these areas here as kind of like that continuum of activity that we're going to evolve towards. And so let me just start by saying this first one is related to prevention programs and life sciences. Now, we haven't done too much talking about this, in the sessions that I've been in this morning. But, one of the things that I see as an opportunity to drive costs down is the prevention programs and life sciences. So I listed a couple things here that for consideration, and hopefully this will spur some discussion with you all. So the intention here is to decrease demand for costly healthcare services through prevention and wellness activities, and we want to leverage advances in life sciences. So one of the examples that people typically are familiar with is how genetics has changed, some of the way that pharma is looking at their participation in this healthcare continuum. And so I mentioned this in a previous session, but you have genetic markers that are identified that might indicate whether a particular drug is going to be effective or not effective for a particular patient. And so now that starts pharma thinking in different ways. Now it's not just, okay, how many doses can I sell? It's, what are they doing and how are the providers viewing this? And so this is one of those changing models, that we have to consider. We need to target human services programs to avoid the costly medical treatments later in an individual's life. I had a discussion earlier about some of the health disparities that we see in different at-risk populations and the adverse effects that are the causes of those disparities. So you know, it's no longer just an idea of, okay, you're either healthy or not, and we're going to either treat you or not. Now we're being moved towards thoughts of, okay, well, what's the actual root cause of some of the chronic conditions that might be experienced later in life? So, nutrition, education, housing, you know, all of those types of things that might have an effect on the human condition early on that might result in some kind of a human condition, adverse human condition later on. Develop individualized wellness programs through some of these preventative services, again, addressing the health disparities, bending the demand curve for costly medical treatments down as a result of that, and then improving that human condition, you know, throughout. And then if you go to the next one, which is patient engagement, and this is okay. So patients engaged in there, I was looking for Don, and oh, there he is back there. Patient engagement. Patients are in the future going to be engaged in their own care. And there's different ways that you might be able to do that. One of those ways is that we're, through a generational change, we are going to experience a change in our consumer model, that where the consumers or the patients are going to insist and expect that data is available to them related to their own care. And we're probably already seeing that, you know, quite a bit. And patients will seek the information that allows them to participate not only in their own healthcare decisions, but in their own wellness. In other words, they will now share in the risk associated with wellness and treatment programs, and they should. And this participation may manifest itself in many ways: change personal behaviors, greater out-of-cycle contact with physicians or providers. I think that's a big deal. I think I mentioned earlier that there was a study done that said that 70%, there was a survey, and 70% of the people surveyed said that they would benefit from an out-of-cycle interaction through some electronic means with their provider. And of that 70% that said that, 40% said that it would have helped them avoid an adverse health condition or health event. Probably health event is probably a better word. So this clearly has some legs. You know, I mean, does anybody have an effort that's going on in your respective areas that in this particular area that you want to share with everybody else? Don, did you want to say anything? Here, let me get this to you first. Don and I had a conversation about this, so I know that he's got a couple things to say.
Well, we have a study at the University of Iowa where they're engaging some people with health coaches remotely using our application, but also ones that are then being coached with paper, and looking for how it affects weight loss in terms of being able to be coached remotely for the population there.
Good, good.
My son is a student at University of Iowa. He's a diabetic, and he had an emergency and was treated by that program. He is a health coach, and it was from a parent and from a healthcare provider. Amazing experience. It was so efficient. He's off at college. They check on him. It's great.
Fantastic. Thank you, thank you. So it works. It works. And so this is one of those things where we can probably do more of this, and there's things like, you know, the in-home wireless devices that test that test for vital signs and are automatically transmitted to some kind of a provider or a monitor, whether it's a physician or not. This can result in fewer costly hospital recovery stays. And one thing that I think that this also leads to is, as you just heard, patient retention and review of the information in their own EHR or PHR, their own personal wellness, and they can start to monitor whether they're doing well or whether they're declining. And so they can be more proactive in seeking care if they need to. Okay, so provider transition to the new service delivery models. This is difficult because the providers will need to begin to embrace the patient involvement and interaction outside of normal cycles. I mean, they're going to start to see the value of this. Now, where there's really going to be an issue here, and I think, Kelly, you mentioned this in one of our sessions, where many times there's not enough incentives for these abnormal types of, not abnormal, but these non-routine types of interactions to be paid for. And so there's some kind of an effort that we can all jointly pursue to make sure that what works gets incentivized. And I think the payment models, as this gentleman pointed out before, are going to be the challenges there. Industry is going to move more towards integrated care that promotes provider accountability. I think what I'm seeing anyway is that a lot of providers are starting to become affiliated with systems of services, from the providers to the specialists to different types of imaging services under the umbrella of a payer typically. And so it's all about being able to be efficient and effective within that model. And so that's something that I think is going to happen so that you can bend the cost curve down and still have everybody retain some level of profitability. And I think that what we're going to have is we're going to have a more effective information exchange across all of that as a result. But this is going to be a challenge. The providers are going to have to go through some changes here in their business models before we get to this full vision of wellness as opposed to treatment. And we're going to have to find some way to incentivize payment for wellness, and that's what the accountable care organizations are all about, really. But we'll have to incentivize that and move away from the volume payment. Similarly, on the payer side, what we're going to see here is, I think that unless I miss my bet, payers are going to start to become activists. They're going to start to incentivize payment models that produce more accountable providers and move more towards this wellness paradigm. And they're gonna want to decrease the demand for costly services. And I really don't know where they're going to come down on this. But I talked with somebody at CMS, and they said that they have Medicare Advantage, fee-for-service, things like that they're paying for now. And they said that, they used to project that about, 15 years out, that there would be no fee-for-service. Now what they're saying is that it's going to be more like 5 to 10. And they seem to think, this particular individual at CMS seemed to think that it was going to move towards a capitation, type of a model, and that promoted wellness, based on the individual or the population, let's say, the population that a particular provider served. And some of the, and I've mentioned this before too, but when you get into this type of a scenario where you're paying for wellness, then there's a lot of talk about the patient's role in risk sharing. Because, a provider a payer can develop a particular plan that the provider can provide, even personalized services under that plan. But if the patient doesn't follow the plan, then there's some issues. And we just heard earlier about having some ability to monitor compliance with a particular plan and using technology. So that's the part of the technology enablement. So we're going to see more and more of this, within this this transformation. And lastly, I wanted to talk about the performance analytics, and I think that this is something that, and I made that flash just to be aggravating to everybody. So, but I think that what we're going to see is, and what I've already started to see is, hospital compliance officers, are now starting to take a look at either real-time or near-time data capture and data analytics, so that they can be more proactive in optimizing any rebates or bonuses that they might receive, through the incentive programs like those that CMS, like the 5-star program that CMS offers, et cetera. And so they're starting to get really creative about this. And one of the things that I've seen is that they're now starting to look at social media. So it's not just the information that is gathered and the review of that information from the patient side, in a formal survey type of a mode, and those that are in the operational aspects of healthcare that might feed into these bonuses. But they're now starting to mine the social media to say, so like, what's trending in this regarding this hospital and their perceived performance. And so now you can start to be very proactive in addressing some of those issues that are starting to come out, so that when it comes time for your rebate or your bonus calculation, you can optimize that. One of the things that I'm also seeing is benchmarking across hospitals and providers, that comparative analysis of performance. And I know everybody, every doctor I've ever talked to and every hospital I've ever talked to, they love this. They love having people tell them how good they're doing or not. And so, this is going to be a tough one too as we move forward. And then I think the correlation between dollars spent and patient outcomes are going to start to be made. Your chief financial officers are going to be very interested in this. And so, the whole idea that it goes back to that value, paying for value rather than paying for volumes of treatment. And I think that I'll leave it there and say thank you. And now, before we leave, does anybody disagree that this is the direction that we're moving? Would you like to offer a different perspective? I'm open to it. Yes, sir. He's going to lay me out now.
Hi, I'm Dick Thompson with Quality Health Network in Western Colorado. I don't disagree with the direction. What we're struggling with out there is how to align the financial incentives and consequences of patient and provider working together, along with the payer community. It's really a financial alignment between the three. And what our concerns are is that until we get to some kind of benefit redesign kinds of environments, so that we can help incent patients to change behavior. The carrot and the stick, I think we found out relative to behavior that the stick works better than the carrot. And so I'd be interested in your comments about, so far the payment reform's always about the provider side. I'm not seeing enough on how we motivate patients.
Yeah, I think that's absolutely right. And so one of the things that we talked about earlier today in an earlier session was the fact that the particular set of legislative material and the regulations associated with that, jury's still out. We haven't really seen the effects of all of this, change. But we don't see, across the patient, provider, even employer and payer communities, we don't see the alignment of incentives within a consistently applied framework that would do what you just described and actually encourage, changes in behavior, particularly on the patient side. And obviously that's where we really want to see the improvement is on that patient wellness so that we can avoid, the costs down the road. And so I don't have a clear answer to that, but there are starting to be some types of thoughts on the patient side anyway, where I call it the auto insurance model, where for patients that are willing and effective participants in their own wellness, they start to get some kind of a monetary advantage to that. So maybe it's lower premiums, maybe it's reduced co-pays, different things like that. I don't know which way it's all gonna play out. But when you start to see variances in premiums, that kind of goes against some of the legislative intent that we're all working in now. So it's a tough one. I see more change coming down the road as we see the effects of all of this legislation, rather than less change as things reach their deadline. So, I'm with you. I'm not seeing the full array of incentives that would allow us to affect the positive change that we need. Anybody else? Yes, ma'am.
Thanks, John. This is more of a sociological question, and I think we have a few physicians in the room, and coming from a College of Medicine, this changes. What you've just laid out here fundamentally changes what it means to be a physician. And what I'm interested in hearing from some of the physicians in the room is what should change about medical education to prepare new physicians for this new world?
Okay, I knew you were going to raise your hand. I was looking for you, actually.
So everyone that goes to medical school just gets to do it once. So you can't compare what your medical school experience was with the next guy. So depending on where it was, what part of the world you were serving, affects the mission of that medical school and the training there. Where I trained, it was in northeastern Canada, so we were taking care of people for Newfoundland, Labrador, and the Northwest Territory. So it was thousands of miles. And there was also cultural sensitivities because we cared for the Inuit people, which had a very different way of living than we, and spoke a different language. And there were all kinds of cultural challenges, flying people in from some outpost that was typically in distress having babies, because the Inuits are half Chinese and half Native American, so these heads were always getting stuck in pelvises. So anyway, we would have all kinds of interesting issues to deal with when we got them in our big center. But what we did learn there was to take care of the whole patient, and we didn't have a lot of money. And we knew, because it's a socialized system there, what the cost of everything was we ordered. And so I think that when I came to America, no one seemed to have any respect or even understand what the cost was of an echocardiogram or an MRI, which we didn't even have access to at that time there. But an echocardiogram would take 6 months to get. And so we had to know how to use a stethoscope. And I think there's still some value in these basic skills. Bedside diagnostic skills, which are basically going away now. You can have a stethoscope that has an ultrasound unit in it, but it's expensive. Wouldn't it be nice if you just knew what you were listening to when you put the thing in your ears? And I think we have to have some practicality, and we've lost that. Number two, the effect of the pharmaceutical industry on how we're trained, because the knee-jerk reaction in training now is, what did you say is wrong with you? And what drug can I give you to fix that? And I think we're going to have to get away from that. And the lack of respect for the cost of these things, and the fact that according to the Institute of Medicine, what we kill in excess of 100,000 people a year from adverse drug effects. We need to stop doing that. So I think those two things, and then motivational counseling, we really don't know anything about it. We don't know how to motivate people. We're not taught to do it, and we're really not taught much about nutrition or prevention. And so that whole paradigm needs to change, rather than us just being taught to be reactive and treat people for acute medical conditions. Thanks.
Okay, great. So I'm getting the hook here. You and I could talk about this for forever, and I think that it would be valuable conversation. So my email address is up here. I am with KPMG, so jteeter@kpmg.com. If you want to get in touch with me about a topic that we've talked about here today. And I think that Jess is telling me that my time is over. So thank you very much, everybody. I appreciate your participation.